Hello and welcome to That Implementation Science Podcast, the show that aims to reduce the innovation to implementation gap to 16 and a half years. I'm your host, Mike Pullman, and on today's show, co-host Kevin King and I interview Rani Elwy about her work at the intersection of implementation science and policy as she served as the Robert Wood Johnson Health Policy Fellow for Patty Murray in the U.S. Senate, focused on menopause care. We'll talk about menopause policy, stigma, implementation and de-implementation challenges for menopause care, and what it's like to work as a policy fellow in the Senate. Today's show is sponsored by the Society for Implementation Research Collaborative, or SIRC, the world's premier implementation science professional organization. If you've ever spent 6 months defining an implementation construct, well then SIRC is the place for you. Check out SIRC's website to see the resources they have available and how to become a member. All right, hello everyone. Welcome to the podcast. I'm so excited to be here today, as usual, with my co-host Kevin King.
Hey everyone.
And with Rani Elwy. Rani is the Warren Alpert Foundation Professor of Psychiatry and Human Behavior and Professor of Behavioral and Social Sciences at Brown University and a Veterans Administration Research Career Scientist. She's a health psychologist, a health services researcher, and an implementation scientist and founding director of the Brown Research on Implementation and Dissemination to Guide Evidence Use, or the BRIDGE program. Every good implementation scientist has to have some good acronyms. That's excellent. And the BRIDGE program fosters the translation, spread, and scale up of evidence-based practices into routine clinical and community-based care. Dr. Elwy's research examines patients' access to and uptake of behavioral health care, the effectiveness and implementation of complementary and integrative health services for treating mental health disorders and pain, and crisis and risk communication between patients, families, providers, and health systems. Although today, we're mostly going to be talking about her work Wood Johnson Foundation Health Policy Fellow for Kevin and my state senator from Washington State, Patty Murray. So welcome to the show. It's so nice to have you here, Rani.
So happy to be here. Thank you for inviting me.
Yeah, this is going to be great. I want to start off just wanting to know a little bit more about how did you integrate research evidence into policy development when you were working? I guess maybe just start with how you got invited to be a policy fellow and lead us through that.
Well, the Robert Wood Johnson Foundation Health Policy Fellows Program has been going on for 52 years. So I was in the 51st class, and
Wow.
So now there's a 52nd class. Yes, so it's a very long-standing program, and it brings practicing health professionals or people who work in the research space in healthcare to Washington, D.C. It's facilitated by the National Academy of Medicine. And so you spend the fall semester, sort of September to December, in training, which is an amazing experience. I felt like I got a political science degree during that time. You think you know a lot about how government works and how laws are made and all sorts of things. And you learn pretty quickly that we have a very complicated federal government on purpose. And we needed to spend a lot of time learning about that. And then during your orientation, this fall period where you're getting training at the National Academy of Medicine, they also facilitate you meeting with different members of the House and Senate, different committees on either side. And you sort of come to a decision, almost like not quite, but like a medical residency matchmaking process where you're like, this is what I love to do. And this office really, does this so well. And I came to DC thinking I would work in a Senate committee. Like I just felt like committee work was what I wanted to do. And committee work would be a deep dive into something very specific. And in the end, I worked in a personal office, and I was the very first health policy fellow in Senator Patty Murray's office. She regularly has defense fellows, but she's never had a Robert Wood Johnson Foundation Health Policy Fellow. And so I felt both an enormous sense of pride to be her first fellow, but also an enormous responsibility to make sure that she continues to have health policy fellows in her office. And I really wanted to be in her office because, first of all, she's the ranking Democrat of the Senate Appropriations Committee. She was the chair when the Senate was majority Democrat, and now she's the vice chair. So she oversees all 12 subcommittees of appropriations, which is very complex. And I wanted to know about appropriations. And she has a really strong focus on public health, women's health, health of children, people who are disabled, the elderly, and also veterans. And so all of those things just really resonated with my own passions. And I was absolutely thrilled to be able to work in her office.
And that's fantastic. So tell us a little bit about what does a health policy fellow do, especially because you were a trailblazer in this office. So how did you begin to integrate the research evidence and your own knowledge of research into policy development?
So I became a member of her health legislative team. She has a very large legislative team in her personal office, and we work separately with her committee staff. So she's, a senior member of 4 committees, along with being vice chair of the Senate Appropriations Committee. She's also a senior member of the Budget Committee, the Veterans Affairs Committee, as well as the Health Committee, the Health, Education, Labor, and Pension Committee. She's been chair of all of those at one point or another. Her entire legislative team is about 20 people in her personal office, and 2 of those people work only on health. And so I joined them. So Shauna Rust is the health policy advisor, and Tara Hartnett is the health legislative aide, and I became the 3rd member. And I was there to really learn about the legislative process from them. But I learned pretty quickly that the benefit that I brought to the office was my knowledge of various health research topics. So mental health and substance use treatment. But also I had done a lot of work in the infectious disease space around HIV and HIV prevention, also in COVID-19 vaccine uptake. And various pieces of that kept coming up throughout the year. As you know, 2025 and 2026 continues to be these are very difficult times for funded research as well as public health. And I was in an office where I got to see how diligently people were working to really fight back against the different mandates that were coming down from on top about how we fund public health, the focuses the full side that we have, where should we put our efforts into research. But generally speaking, I tell people all the time that our ability as researchers to digest information quickly, think critically about what we read, and then put into writing in very clear ways is the most important thing that I ever did as a health policy fellow. So whether it was a new study came out about the relationship between fluoride and children's IQ, which in the very beginning of 2025 was in the news a lot. My job was to read this very dense meta-analysis quickly and summarize it, and also provide some analysis of whether or not this was really representative of the science in the field. And, to do that in 2 paragraphs, which is not something a researcher does very well, but I had to learn how to do that very well. And then, I might have had 2 hours where I just worked on that really quickly and hard. And then another topic would come up. So another thing as a researcher is to really understand what you know and what you don't know, and to ask questions of other people because you move so quickly between them. But, I would say that it wasn't so much my research knowledge that was important. It was my ability to read critically, think quickly, and write quickly and clearly. That was the important piece.
Yeah, and as researchers, we love nuance. That must have been challenging to try to summarize something where there's a lot of nuance involved in a way that's actionable. And I think that's one of the challenges just in research in general. How did you handle this maybe cognitive dissonance?
Yeah, you do need to come down on one side or the other. And there are some places that it's really easy to come down on one side or the other. Vaccines work. They prevent disease. Investing in public health saves lives. It's really easy to say these things clearly and succinctly and to make an impact. There are other things where it's harder, but the skills as a researcher that we have of talking to other experts in the field, being able to learn from those that we all know, and so when I was there and I was tasked with certain activities, I would ask, is it okay if I reach out to people I know and ask them? And sometimes the answer was yes, and sometimes it was no. It really depended on how sensitive a topic was and how quickly we needed information. But I mean, I have so many things to say about what we as researchers can do to help the process of moving evidence into policy. But the most important thing I would say about it is that we need to get our research out of peer-reviewed journals. And if there's anything that any of us can do to help a policymaker learn about our research and get it into policy, is to either publish an op-ed in a well-read, newspaper or, media, magazine, or get a journalist to write about our research. I don't know which one is easier or harder.
Yeah, start a podcast.
Or start a podcast.
Nobody listens to podcasts anymore, Mike. Nobody.
No, I don't think
dying
that's true.
art.
I think, yes, all sorts of non-traditional research media are welcome. Because as a staffer, so I was in effect a Senate staffer, and I am given such a short amount of time. Like when I said 2 hours, that was early in my foray into being a Senate staffer. So they gave me some leeway. It's not usually 2 hours. It might be an hour, could be half an hour. I've got to become an expert in something so that I can write up a memo and share it with the senator, which is going to inform a vote that's going to happen on the floor. And, even though I have all the skills to look up an article in PubMed and get it from a journal and read it, I don't have the time, but I do have a lot of time to go to the New York Times or the Washington Post or the Atlantic or somewhere and find out what have they written about it. And then I can synthesize that. They might reference a study and I'm going to have to take it at the word that they've actually done a good job of that. And so we need to get our research into those places so that someone like me sitting in an office of a senator who has a lot of influence and power can get that information and share it with the senator.
Yeah, so I'm curious when we're doing that as scientists, say we're going to try to get a reporter on a story about our work, or we're going to write an op-ed about stuff that we think is important. How do you think the timing matters? Sometimes there's fluoride policy is in the air because people are promoting sort of false information about the negative side effects of fluoride, for example. And then you're talking like, oh, the senator has to go vote on a bill or is going to do a hearing on something. Is there any strategy involved for scientists in timing it? Or is it more like if you have a good study, get it out there because somebody will go back through and do the research to find it? How do you sort of balance those things?
I think it's both. I don't want a good paper, say we're publishing a high impact paper, like we need to do an op-ed to let people know about it at that same time. But if we also know that a member of a cabinet is going to have a hearing and they are focused on 3 things that we know are incorrect and wrong, we can also get the message out at that time. So it's both. And, I think right now, it's important for us to do the former. Like if I'm going to be publishing a paper or giving a talk or something, I want other people to know about it who aren't in my scientific circle. But I think also through that process, a journalist will recognize that you're an expert in that space, and then they can come to you. And so maybe if you can't get something out at just the right time of a hearing or a nomination process or anything, a journalist is paying attention and they have seen that you've written something already on this topic, maybe 2 years ago or whatever, but they can come back to you and ask you, well, what are your thoughts now? And so that, and also just being open to that, being willing to speak. And I know that many of our organizations and institutions, have all sorts of their own policies in place about how easily we can speak to the press. But I think we need to push back on that because I want our voices to be heard and our knowledge to be shared so that we can overcome other voices that are perhaps louder than ours right now.
Right. And as you said, we often have the ability to speak with nuance and with credibility and with authority. and sort of speak from the data. So, it's a lot harder to argue. I guess we make strong, credible arguments is what I'm getting at. One of the things you talked about in this policy fellow position was having to become an expert on all sorts of things you weren't an expert on. I wonder if you could maybe step back and talk about what your work has been on, where you do find expertise, and tell us how that informed the work you ultimately did on menopause policy at the intersection of clinical care, research, and policy.
So I'm a research psychologist by training, and I did a health services research postdoctoral fellowship where I was introduced to the lovely concept of team science, and that was brilliant. I loved being able to work with people in so many different areas, all of us focused on quality and access to healthcare. And then I also learned about implementation science, and which I feel like implementation science came from two strands. There's a health services research strand, and then there's also, in my experience, a clinical psychology or clinical social work strand. And those two things have come together, and we have this amazing field of implementation science. So I started out being much more of a mental health, behavioral health researcher, really focused on, what is the effectiveness of this particular type of treatment? And I have been working in the VA healthcare system ever since my postdoc, which was many years ago. And, the VA has been a great place to be both a health services researcher and an implementation scientist because we're embedded researchers and we work so closely with medical center leadership, regional healthcare leadership, and also central office. And so if we had a really good idea, we had a health system in which to test it out. And then I really became the kind of person who was like, look, we don't really have, sure, there are some things we still need more evidence for. There are still some things that we need to test the efficacy of, but we have a whole bunch of evidence that is just not reaching patients. And that's why implementation science became something that was so important to me. And it became less of a sort of primary data person, generating the data from trials or observational studies, to being the person who says, look, you've got a great intervention and you have great data. I want to take that and run with it and try to get it into practice. And that whole pipeline really stopped for me at the policy space. I learned early in my implementation science career that if we didn't change policy, we were never going to be able to sustain anything that we were implementing. And I was looking around, how am I going to learn this? I don't know anything about policy. I talk to policymakers in the VA healthcare system, but I don't talk to people outside of that. How does Congress work? What is the role of a federal legislator versus a state legislator? How am I going to learn about that? And I learned about the Robert Wood Johnson Foundation Health Policy Fellowship and realized it was a residential placement in DC. And it isn't the easiest thing in the world to put your research career on hold and move and, take your family with you, or perhaps sort of take your family with you. My family moved back and forth between Massachusetts and DC the entire year that I was there. So I had my eye on it and was just waiting for the right time. And that coincided with a lot of other career pieces that just all aligned, and I applied and was accepted. And it was honestly the best thing I ever did. But it gave me an insight into how policy is made that I never would have understood. And also, how is the money appropriated to make sure that that policy is actually going to work? Because I really didn't understand the difference between authorizing legislation and appropriations. And that may sound really silly to people who know a lot about those things, but I thought a law was a law. But it's not. You can create an authorizing piece of legislation that has literally no funding, which in effect makes that law moot. There's no money for it. So who's going to enforce that? How's that going to be carried out? And Senator Murray is this brilliant appropriator, and I needed to know from her team, what do we do? Like, what are all the paths? And so I say to people who are in research, just like we might take a grant proposal and submit it here and then repackage it and submit it there, you do the same thing with legislation. You might try the authorizing route, and you might try to then get funding for it through the appropriations part, or you might just try to do appropriations report language, which just goes right into the appropriations bill. So there are multiple ways. You can also then tag it on to a must-pass piece of legislation. And in our country, that's the National Defense Authorization Act. It is never not going to pass. We are never not going to fund the military. And a lot of pieces get added to that as an amendment, which may or may not have anything to do with military, but they get added in because we know it's going to pass. And that allows for both the authorization and the appropriation. And so, we're really skilled at knowing where to send our grant proposals and how to get those funded. And the same thing happens on the legislation side. We have this tactic. That doesn't work. We'll go here and we'll try that. And sometimes we try them simultaneously and we see what hits. So as a researcher, I got to participate in both authorizing legislation, helping to co-write something and also edit other legislation from a previous Congress. And I also got to work with legislative teams, the committee staff, to write appropriations report language, all in the menopause research space. And you asked me, Kevin, what is my research? I don't do menopause research, but we all know what health research needs to do. And women's health is very personally important to me. And so I took all of my own research skills and ability and applied it to an area that I didn't know very well, and drew on the expertise of a lot of researchers across the country, some of whom might hear this podcast, and really benefited from their own expertise to inform me, what should be in this legislation.
And so could you talk to us about what that looks like? What is menopause policy, and what are some of the areas that the legislation you worked on address, or maybe even what were some of the problems that it was trying to fix?
So Senator Murray introduced a piece of legislation in the 118th Congress. So before I joined, that was in the year 2024. And that piece of legislation was called the Advancing Menopause Care in Midlife Women's Health Act, S4246. That was introduced in May of 2024, and it was introduced with a lot of fanfare. Halle Berry is an advocate for this. She came to Washington, D.C. and was with Senator Murray and Senator Lisa Murkowski, who were the leads of that research. And every single woman senator signed on to that, so Republican, Democrat, and it was a really remarkable thing. And it did not actually pass in that Congress, so it needed to be reintroduced. I was given the opportunity to provide some edits to it. And that's when I, approached the health legislation team that I told you about that I was working with and said, if I were working on this as a scientist, I would reach out to experts in the field, just have a conversation with them. I said, is that something that I can do here? And they said, yes. And so I sort of did a snowball process where I would reach out to people working both in the VA and outside the VA to find out, if, and this was a research bill, these were research bills. So this Advancing Menopause Research Act was meant to have the NIH fund, the CDC fund, AHRQ fund, different aspects of menopause research. And it could be like in the NIH side, establishing centers of excellence for menopause research. It could be on the AHRQ side, training providers on how to actually provide menopause care. And on the CDC side, it could be like public health campaigns around, what menopause is and what we should do about it. And then I was able to edit really great information from the people I spoke to who said, menopause is not a one-time thing. There's perimenopause, there's postmenopause. And so I was really able to bring the whole menopause pipeline into the research activities and the public health campaigns and the training of providers that we wanted to see. They also talked about how the treatment that is offered, hormone therapy, there could be other forms of therapy that are really important for menopause. We don't talk enough about psychological and behavioral therapies. We don't talk enough about complementary integrative health therapies. We don't talk about non-hormonal treatments. They don't always have to be hormonal. And so people in the field who were doing this research said, we need to be much more expansive. We talked about things that we all know work that we see in other types of healthcare, such as the, care coordination models, the chronic care model, those types of things. Like menopause is a space, just like a lot of other aspects of health where you need specialties from all over. You need them from orthopedics, you need them from neurology, you need them from genitourinary care, so urologists. You need all these, primary care, family medicine, of course, OB, GYN, all of those people, and they're never housed together. My son has a neuromuscular disorder, and no place, very few places, have everyone you need under one umbrella, which just makes it so difficult for people to get care. So this Centers of Excellence model would have addressed that. And really, I am so surprised at how difficult it is for people who train in OBGYN to have conversations about menopause. If they can't have conversations about menopause, who can? And so we took a little bit of that update that I did to that piece, and we introduced another bill, which was called Service Women and Veterans Menopause Research Act, S1320, which was introduced in April of 2025. And that was Senator Murray was the lead on that with Senator Jody Ernst, and they introduced that, and it went into the Veterans Affairs Committee. And that nearly passed. It became part of the National Defense Authorization Act. And it would have taken just a little bit of what I just told you about, not as extensive, not the whole Centers of Excellence approach, but it would have a lot of training of providers. It would be doing a landscape of both VA and DoD research on menopause and identifying what was missing and creating a research agenda and then funding research in that space. And that would have been incredible. We actually know that service women and women veterans are more likely to have early symptoms of menopause as a result of toxic exposures, as well as post-traumatic stress. And what are menopause symptoms, perimenopause symptoms in this population are seen much earlier than in a non-military, non-veteran population, which is not well known among providers. So it would have provided a lot of training, and it would have actually also tracked if women veterans and women service members were actually getting care sooner and what types of care.
That's fascinating. And I know one implementation strategy at the policy level is to find special populations, certain populations, especially veterans and children, for whom good healthcare would apply, to the broader population as well. But these populations are considered, more of greater interest, and they have oftentimes greater support, I guess, at a bipartisan level. I'm sorry that didn't pass. There's, possibilities in the future for this.
Big thanks to SIRC, the Society for Implementation Research Collaboration, for supporting that Implementation Science podcast. SIRC is a mix of researchers, practitioners, and policymakers who are all trying to answer the same basic question. How do you make things work out there, not just in a paper? They're also behind the journal Implementation Research and Practice. Join us at SIRC during their biannual conference in beautiful Minneapolis, Minnesota, the Waikiki of the Midwest, on September 25th and 26th, 2026. If you enjoy thoughtful science, real-world problems, and overthinking both, become a member today.
So I wanted to ask you a little bit about why menopause historically has been so relatively invisible. Estrogen isn't exactly a niche issue. And so kind of curious if from an implementation standpoint, it's so important for us to look at barriers and facilitators to implementation. And so is this invisibility kind of in your mind due to stigma and cultural narratives, or is there some sort of implementation failure at the systems level that's contributed to this? You mentioned one earlier, actually, the sort of lack of care coordination across all these different levels. You mentioned OBGYN and endocrinology and on and on. So that's probably one. Are there other implementation failures that have contributed to this?
Well, funding is a huge barrier. The NIH's women's health budget has been exceptionally low. I think 0.2% of the 2024 NIH budget went to women's health and menopause specifically. And so it's really incredible that a condition that impacts literally more than half of the globe is so underfunded. And any research that you have heard or read about that has come out, a lot of it comes from University of Washington with the Women's Health Initiative that University of Washington has a coordinating site for. And a lot of the research on menopause was done in the context of like cardiovascular disease, but they were able to follow women for so many years. And so obviously this population became older, and they started to see impacts of aging, and they were able to make not just correlations, but causation, that at a certain point, there's a relationship between heart disease and menopause. There's a relationship between menopause and Alzheimer's disease. There are, like, in my own research on menopause that I did to understand more about it, to inform the edits I was making to this legislation, hot flashes, which have been laughed off by generations of women and their loved ones around them as just like, oh, just, wear sleeveless shirts to work so that you can take your jacket off. That actually creates like sort of like these like flashes in the brain, which start to mimic and attribute like cognitive impairment. And over time, perhaps lead to greater Alzheimer's disease presence in women. There's a reason that 2/3 of Alzheimer's patients are women. And they think that the relationship is having to do with, untreated menopause. And so these are the kinds of things that come out of like the Women's Health Initiative, that those were not primary research questions. Those were things that they found along the way. And I think that, knowing that our own providers don't get that kind of training, a study of like OBGYN residents said that like 30% of them, like only 30% of them feel confident in having a conversation with their patients about menopause. And if we can't have women's health providers talking to us about menopause, like how can we expect anyone else to?
Yeah, and I would guess most women would think that OBGYN should be the person they should talk to. I only learned recently that's not. It should be endocrinologist you should talk to. But even the OBGYNs don't know to refer people on to endocrinologists. If people are coming in with perimenopause or at early ages, they get discounted. Or even at later ages, their symptoms get discounted. We're not really considered because, again, everyone thinks this OBGYN is the person they should be talking to. It's fascinating that the training doesn't extend to that because of the association of that with women's health issues in general. Are there things that we need to de-implement? Are there harmful practices out there that we could get rid of that would allow greater space for better implementation around menopause care?
The menopause researchers that I spoke to really emphasized the fact that women who are experiencing menopausal symptoms are going to treatments that have no evidence because that's what's available to them. So, all of these like herbal treatments that they might read about, I don't know, St. John's wort or something, people go to those, and you can easily Google like menopause treatment and up will come like some completely untested, non-evidence-based herbal supplement that you should take. I've had people say to me, I'm taking this, and I say, there is no evidence for this, but those things are available. Whereas having a conversation with your doctor and getting informed about, what is available to you doesn't happen. KFF did a survey that showed that like more than half of women of menopause age were not having conversations with their doctors. So I think that this lack of conversation is the biggest problem. And that's why we put that into the Service Women and Veterans Menopause Research Act, because it required doctors to have training and then have conversations with their patients about what treatments were available to them. So what the menopause researchers I talked to said, like, we need to do research to inform what works so that we can also then get these other things off the market that shouldn't be there. Mostly a lot of herbal types and a lot of small companies that have emerged that, have their own products and they say that they work.
Yeah, just while you were talking, I did 2 quick Google searches for menopause chiropractic treatment and menopause acupuncture treatment, both of which are imaginary treatments using imaginary mechanisms. And both of them, the AI summary both said, can be safe and effective to manage menopause symptoms, when we know there's no possible way that research could be confirming either chiropractic or acupuncture. So I find that it's interesting, and you imagine people doing that sort of thing are just going to get positive search results, right, in our sort of AI dominated and marketing dominated space. Yeah. So it seems to confirm and reemphasize your point that we need to have a bigger presence of evidence-based practices and evidence-based care.
What would you think? For those of you who enjoy chiropractic or acupuncture care, please recognize that Kevin's email address is Kevin M. King, at UW-WVU.
And I think that acupuncture is a fabulous treatment for pain. There have been many studies that have shown this, and you could have some pain in menopause. But what we would like you to have is a holistic approach to your menopause symptoms that is not just like one off, and that individuals don't have to decide their own treatment on their own, that they should have conversations about this. This is what we want. And we want trained providers. So like the Menopause Society has an amazing training that you can take. And then they have a list of providers who across all different specialties who've taken that training. I am not a spokesperson for the Menopause Society, and this training does cost money, which is why we wanted this bill passed so that this training could happen in other ways. But the Menopause Society does do this training, and it's excellent and it's evidence-based. And a lot of the women that I spoke to, a lot of the people doing the research in the menopause research page are affiliated with this and they recommend it, but not everyone can afford to take it. And we need to have a public health service in this country that is training our providers. We need to make this part of medical school curriculum. We need to make this part of like continuing education. It needs to be much more than just one society who is providing this training.
Right. I mean, we were going to ask you about the biggest implementation barriers to evidence-based menopause care, but I think you're identifying some of them, right? We need, broader education. It needs to be infiltrated sort of throughout the medical and secondary, post-medical education system. You talked about care coordination because you probably want folks from multiple specialties. I guess maybe what's the biggest implementation barrier to getting evidence-based menopause care out there that you think you haven't mentioned yet? Or what change would make the biggest impact sort of at the national policy, or national health level?
I know I've already talked about communication, but one of the things that I have enjoyed so much as a result of my policy fellowship doing is saying the word menopause a million times. It's like one of those words, Michael, you brought up stigma earlier. I think it's one of those words that inherently has like a stigmatizing perspective of it. And by normalizing menopause and saying the word, I actually, part of the requirement of the RWJ Health Policy Fellows Program is to do a end of year presentation on some policy topic. And I chose, promoting menopause research as part of a federal health policy agenda. And I gave a talk to a room with a lot of men. And I said, I'm going to say the word menopause like 60 times in the next 10 minutes. And I'm going to love every minute of it. And I think that we need to say these words out loud that people haven't been able to say. I think so many parts of women's health are like that. We could never say like menstruation and period and all these other things. And I think menopause is at that space where we just need to say it more. When I say to people, 50.5% of the globe is female.
Whoa. This is a family show, Rani.
They are all going to have menopause. Every single one of us. That isn't like, it's not a disease. It's a normal part of aging. And why are we having such a hard time just saying the word out loud? So I'm on a campaign to say the word as much as possible. I bring it up with my doctors. I actually learned through a meeting that Senator Murray had with one of the Delta Dental CEOs, who her own mission is to bring menopause into conversation with dentists, because something I did not know is that teeth and gums are impacted by menopause. And so a lot of women start to have a lot of problems with their teeth as a result of menopause. And 4 out of 5 dentists are not talking about menopause with their patients. And women want their dentist to talk. Dentists want to talk, but don't feel confident in talking. And so she's making this part of her dental agenda. And so I love this. So I came back from my policy placement, came back home, went to the dentist. He asked me how it was. And I said, you need to talk about menopause with your patients. And we had an entire conversation about it. And so literally, it's so important to have this conversation. It feels so simple, yet it is lacking everywhere.
Speaking on behalf of Kevin and I, we feel a lot more comfortable talking about Viagra than menopause, but here we are.
Mike, I'm just thinking this episode is going to be really short once we bleep out all the mentions of menopause, so we can keep this a family podcast.
I totally agree with you, Ronnie. This only became something that was on my radar recently as my girlfriend entered menopause, and then I started reading about this and hearing people talk about it. Shocked that OB/GYNs didn't know more about it. But I also know that the country is becoming much more aware of it. I've been talking about it with my kids who are quite young, and they actually are getting a little tired of me talking about it. But to think about even in like sort of health class in middle school, it's not a topic that has typically been covered, even though it doesn't impact just half of the population. It impacts all of the population because we're
That's
all
true.
connected. Yeah, yeah.
Very good point. Yes, it impacts everyone who has a female in their life and who is going to experience this. And people did say that in the room where I gave the talk. So I appreciate them reminding me that it affects more than 50.5% of the global population.
Yeah.
Way
So
to
well said.
mansplain
I since
menopause, Mike. Good job.
I just mansplainopaused.
Well, I will say though, having men talk about something that impacts women is so critical, right? So that we are all in this together. And there have been cases of male elected officials who very much realize that this is an important topic. They, like when Senator Murray's Advancing Menopause Research Act was introduced in May, some men wanted to sign on immediately and they wanted to sort of start with the women senators. I don't remember at the time if there were 20 or 25, but they wanted to have them start it and then they could open it up. But like having those early adopter men elected officials is really critical to this. Obviously this can't just be a women's issue.
Well, I mean, speaking about issues and how it can't just be one issue, actually, I think, if menopause is like every other health condition in this country, it doesn't affect all women equally. So was wondering if you could talk a little bit about how race and socioeconomic status shape menopause access and care.
Yeah, I wish I had actual data on that to share, but I will say that one thing that was really clear as we were working on updates to the bill was that there's definitely a geographical problem in menopause care. And so, especially Washington State, which I learned the acronym WWAMI of Washington, Wyoming, Alaska, Montana, and Idaho, that so many of those areas seek their care in Washington State because they don't have a lot of care, and that there are programs where medical students and residents go to the other WWAMI states to provide care. And I know that I read things in, the Seattle Times and other papers about medical students and residents saying, they needed to know more about menopause treatment because they were the only source of that information for people in some of these other states. And given the reach of Washington State, specifically from a medical care perspective, I think there's no doubt that those geographical areas also have socioeconomic issues. So we put in a lot of language into the bill related to rural health because there needs to be more attention to how women in these parts of the world, if they don't have access to menopause treatment knowledge locally, how they can get it. So we wanted to look at would some of the centers of excellence research that was being funded, public health campaign, training of providers, how we could reach those rural health spaces. I would imagine, just because I know the veteran and military population, that, a lot of people who are of lower socioeconomic status and people of color enlist in the military. And if we know there's a relationship between toxic exposure and post-traumatic stress and menopause, that then you're going to see earlier menopause, perhaps a higher frequency of menopause in this population, which is going to be have race and ethnicity, greater, populations of Black women, Latino women, maybe people who are lower socioeconomic status coming out of the military, seeking care in the VA and not necessarily getting good menopause care. So I don't have that data, but I know that it exists and that we need to include it in the bills that we were writing.
Thanks, Ronnie. It's incredible to me that you're not a menopause expert because you really cosplay as one really well. And I think you're your deep knowledge of the policy landscape and your enthusiasm for sort of finding ways to do the right thing is just infectious. This has been really an incredible conversation. And I just want to thank you for joining us today. As we close out, I'm wondering if you reference one or two articles that you feel are most essential to implementation science. Like, what are your kind of favorites? We ask this of everyone and just kind of want to know, what would you tell our listeners to pay attention to?
Well, these are not implementation science specific. I mean, these are not menopause
Oh, sure. Yeah.
specific implementation science. But for example, if I'm speaking to, and I do this a lot through the Bridge program and also through the VA, I speak a lot to clinicians, often physician scientists who may not know about implementation science, but I know that if they knew about it, they would recognize the importance of it. Clinicians, providers, physicians want evidence-based care. And so one of the papers I share with them is this article by Mark Bauer and Joanne Kirchner that was published in Psychiatry Research in January 2020. It was actually an entire special issue on implementation science. And the title of their paper, which is the opening paper for the entire issue, is called Implementation Science. What is it and why should I care? And I just love that. I'm just going to say it again. Implementation science. What is it and why should I care? Mark Bauer, Joanne Kirchner, Psychiatry Research, January 2020. So that's a great paper for clinicians specifically. When I'm talking to people who want to know more about implementation science research and learn more about how, like, what are they doing now? And then how can they move into doing more very focused implementation science research? I love the article by Megan Lane Fall, Jeff Curran, and Renad Beidas on the subway line. You guys probably know this paper, but this was published in BMC Medical Research Methodology in 2019. So neither of these papers are new, but this one is specifically called The Scoping Implementation Science for the Beginner, Locating Yourself on the Subway Line of Translational Research. And it has that really nice subway map to show, does your program of study have efficacy, or does it have effectiveness, or are you ready to implement it? And you can really start to see, map out, what your own implementation science research agenda can be and where you can start to move your work.
Excellent. Those are both great articles. I'm not sure if anyone's mentioned those on our show before, so fantastic. Do you have any shout outs you want to give, and how can our listeners connect with you if they want to?
Well, I'd be very happy for anyone to email me at Brown, Rani_Elwy at brown.edu. And huge shout out to the Office of Senator Patty Murray, the senator herself, her health legislative team, her leadership, Mindy Lindquist, Chief of Staff, Lizzie Letter, Legislative Director, Shauna Rust, who was my mentor, Health Policy Advisor, Tara Hartnett, Legislative Aide, and the entire legislative team. Also members of her committee staff in appropriations, Ag FDA, who, by the way, I was able to help them put in some language for menopause funding for the FDA to invest in on hormonal and non-hormonal treatment for menopause across the perimenopause to menopause to postmenopause pipeline. And that did pass. That is law. That passed in November. So whether the FDA actually invests in menopause hormonal or non-hormonal treatment is to be seen, but it's there. It's law. And her staff on the Labor, Health, and Human Services and Education and Related Agencies Committee as well. So all of those people helped me learn so much about legislation, appropriations, and just what it takes to do great work in the Senate.
Fantastic. Thank you so much. This has been one of my favorite episodes of all time. I haven't even listened to it yet, so I just want to thank you for coming on, and we will talk to you next time.
So happy to have been here. Thank you so much.
Thanks, Rani.
Thank you so much for listening. I hope you enjoyed today's show. You can reach Kevin on Blue Sky at Kevin M. King. Today's show was lovingly edited by our fabulous new podcast member, Valentina Gastaldo, with support from the Society for Implementation Research Collaboration. If you liked today's show and want to show your support, become a member of CIRC. All of the comments and opinions expressed during today's show are our own. They are well-reasoned and insightful, and therefore are probably not endorsed by our grant funders or employers. Thanks for listening. We'll catch you next time.
I'm just thinking this episode is going to be really short once we bleep out all the mentions of menopause, so we can keep this a family podcast.